My name's Olga Janssen, and I'm presenting this case, which is based in London, as a carer in a personal capacity. I'm a friend of the patient called Len Foreman, who died on the 17th of January this year, which was 2 weeks to the day after he had been informed that he had pancreatic cancer, which had spread to lungs and liver. It's not a rare case. 27% of pancreatic patients in this country do not survive beyond 1 month due to late diagnosis. In his case, he had presented indicative symptoms already 16 weeks earlier to his GP at the beginning of October. He did not receive treatment at any point, including palliative treatment, and supportive care was only good for the last 2 days of his life in a hospice. Key issues that are raised by his case: indicative symptoms were not recognised by doctors in both primary and secondary care who had a poor awareness of pancreatic cancer. It's not a rare disease. There are 8,000 cases in the UK per year. Late diagnosis closed down all the options for him, including operative surgery, which is performed at early stages in other countries, but is performed in early stages in the UK and at later stages still in other countries, but it was not a possibility for him. The late diagnosis also meant that he could not receive palliative care, either chemo or radiotherapy, which would have potentially lengthened his life. It would have hopefully shrunk his cancer and prevented further spread of the disease. So he was, in effect, denied time to settle his affairs. There was no agreed and implemented pathway for patients presenting through accident and emergency. 50% of pancreatic cancer cases present through accident and emergency route, and there was no pathway. He presented with thrombophlebitis, which had been in fact caused by his pancreatic cancer. That was treated effectively, but the underlying cause was not discovered despite 12 days of tests. During that 12 days of tests, he had an ultrasound scan, a two-dimensional image, which showed an enlarged spleen. This should have sent up alarm bells. In fact, it was due to infected lymph nodes, the lymphatic system being the conduit of the cancer from the pancreas to the lung and the livers. A CT scan giving a 3D image should have been immediately ordered. It was not. It did not take place until the 19th of December. He had been admitted on the 14th of November. That CT scan showed advanced pancreatic cancer, 10 by 10 centimetre tumour, and metastases, lung and liver. It normally should have been picked up by a radiologist within 48 hours and passed as an urgent case to the upper GI team within the hospital. Instead, for reasons unknown, it went to the homeopathy department at a date unknown. It was not received by the upper GI team until the 4th of January. The homeopathy consultant contacted Len and informed him of the outcome in a one-to-one consultation. He was not invited to bring a friend. It was very difficult for him to take in this news at the time. And at that point, I was called in as a supportive friend to attend his very first consultation with an oncologist. In effect, he was dismissed, I think, the moment they saw the picture that emerged from the CT scan as an untreatable case. He was also denied adequate pain relief until the last 9 days of his life, when he was admitted on the 9th of January to have a biopsy. He won't appear in any national statistics, which is worrying. He will be seen to have submitted far too late for diagnosis to affect any treatment, curative or palliative. The upper GI team will not be seen to be at fault because they only heard on Friday the 4th of January and they saw Len on Tuesday the 5th of January. Tuesday the 8th of January. What I think is most distressing for friends and family is, first of all, that he could not get palliative care, secondly, that his pain was not relieved, and he was denied time to settle his affairs. So, and he was an extremely articulate and resourceful man, and what's worrying is if somebody as capable as him has this sort of treatment, what can you expect if you haven't got that ability? The submission will give you much more detail on the trajectory of the illness and the failings of primary and secondary care, and the family is hoping that there are three things that will arise out of this inquiry that his case is being presented to. Firstly, early diagnosis. Secondly, improved pancreatic cancer treatment. And thirdly, improved survival rates.
Well, good morning. My name's Debbie Wells, and I submitted on behalf of my daughter, Gemma Harrison. In August 2010, Gemma died from pancreatic cancer. She was 27 years old. She was beautiful, vibrant, and very much cherished, and is constantly missed. The main issues that I wanted to address in this submission were around early diagnosis, our overall NHS experience, and the palliative care experience that we had. With regard to early diagnosis, the most important aspect for us was the fact that Gemma went to her GP on a total of 10 separate occasions between the middle of April 2009 and the end of August, when she was finally referred to a specialist for an ERCP. During that time, apart from all those 10 appointments with her GP, she also took herself to A&E on at least 2 occasions, her and her fiancé, because they didn't know what else to do and she was in such pain and distress. At no time was she ever admitted. She was constantly turned away, and by the time she was actually admitted for her ERCP, she was on a complete cocktail of different medications, antispasmodics, antiemetics, and pain relief. But for me, that is such an important issue. And the other thing is that she was very much dismissed because of her age. So GPs, quite understandably, don't get to see many patients with pancreatic cancer, and certainly not many of this age. But for me, surely alarm bells would have been ringing for a healthy, fit young woman who presents more than 10 times to her GP in a short space of time, never getting better, showing classic symptoms of a problem with the pancreas and not being addressed. So there were 2 issues around early diagnosis. Why did it take so long and so many GP visits for her before a referral was made? And why just assume that because someone is that age, in fact she was 26 when she first became ill, that it can't be pancreatic cancer? I was told on more than one occasion by consultants it could be pancreatic cancer, but of course it's not because she's so young. They were totally wrong. It was pancreatic cancer and she died. With regard to our overall NHS experience, the main issues that I think need urgent addressing are the lack of communication between departments within a hospital setting, individuals and teams. I observed very many times the fact that the communication pathways were not working, they weren't flowing properly. For example, we desperately needed some dietary advice with Gemma when she was in hospital. I forgot to say where I'm from, actually. I'm from Surrey, but actually Gemma was treated at a combination of Southampton General, Royal Surrey, and in fact at North Hants, because she came from Hook in Hampshire. So I was staggered to find that actually the dietitian, whom I thought was really key to this disease, was not part of the multidisciplinary team. I wrongly assumed that that's what multidisciplinary meant, that it actually did bring together everyone with their own specialisms coming together to talk about their patients. And by the time we saw a dietitian on the ward, my daughter was clinically malnourished, was having to be intravenously fed TPM food supplements, and was told that if she didn't start eating properly, she'd have to have a nasogastric tube. I couldn't believe that, in fact, a dietitian wasn't involved in any of this, in any of her care, in fact. And to me, that was just such a glaring omission. And it came from the lack of communication. And when I spoke to the dietitian about it, her actual words were, "Oh, we're not allowed into those meetings." The other thing that I found really that really affected us was the lack of privacy and respect afforded patients, particularly cancer patients, in a hospital setting. Now, this doesn't really only apply to patients with pancreatic cancer, of course. I think it's a general thing. But we were told constantly some very personal and sensitive information, and each time a flimsy curtain was pulled around her bed. Very often, the doctors seemed to think these are soundproof. They would walk in and big booming voices would talk about our family's very tragic situation for the whole ward to hear. And this led on to another issue that for me is key in dealing with cancer patients at any levels, and that is to be given your diagnosis in a place of privacy. We were told, I was told actually, I was the only one there from my family at the time, that my daughter, who at the time was 26, was suffering from inoperable pancreatic cancer. I was told there was nothing that could be done for her, and I was told it at the side of her bed, with the flimsy curtain pulled around, and I was also told it in the middle of a medical emergency, because Gemma had just suffered a severe esophageal hemorrhage, and it was chaos around the bed. There were doctors coming and going, nurses rushing around. Gemma was in absolutely no fit state to be told that kind of news, and neither was I. So those are the issues that I think overall, obviously there is a lot more in the submission, but as an overview, it's the communication and the lack of the lack of privacy and respect and compassion that should be dealt to every patient. There was a distinct lack of healthcare and nurses on the wards. They were all stretched to capacity. We know how hard they work. I saw it every day. I was on the ward every day, all day with my daughter. I witnessed and observed it. They are completely stretched, and there just isn't enough of them. The only time this changed was when my daughter had to go into ITU, where the level of nursing care was exemplary, because it was one-to-one, and it was focused and directed and very patient-centred. On one occasion, I was told there was only one oncology nurse on night duty at the Royal Surrey. Gemma was very distressed. She wanted someone to be with her. She was vomiting constantly. I had gone home. I'd rung up again an hour later, and the nurse said, "I'm really sorry, I can't sit with her. I'm the only trained nurse on duty tonight," on an oncology ward, a ward full of sick patients. So I went back up and stayed with her till about 3 a.m. myself. After all this experience, and we crossed the line to palliative care, Gemma came home to be cared for by myself and her family with the support of the GPs, the district nurses and our local hospice. Things did change. Once we moved to palliative care, things moved. People communicated. The phones rang. I didn't have to wait for an OT. They turned up the next day. Any request I made was answered. And I do feel it's really very strongly that healthcare trusts and hospitals could learn so much from the hospice model of care. You never hear about a complaint regarding a hospice. Usually you will hear praise and good things. You always hear complaints about hospitals. The hospices are doing something right, so I think their care models should be replicated out in the hospital setting. I just want to say, as I said, there's a lot more in here, but that's my key points. But I would like to just say, in conclusion, I need to just pay tribute to my daughter, because throughout all of this ordeal, she was incredibly brave and serene. And I hope that the work that we're doing here, and I hope that the conclusions that are made and the recommendations that are put forward will in some way make her very proud of what we're doing, because we were certainly very proud of her.
Lynn Walker. I'm talking about my experience in Suffolk and my treatment in Ipswich Hospital, the GP Suffolk-based. Yes, well, one of the two things that I want to say, very common to what's already been said. I think the first thing I want to say is that I went to my GP more times in the previous 12 months, the 12 months prior to my diagnosis, than I had in the previous 12 years. I was reasonably fit and healthy, I had the usual sort of things, but actually the fact that I kept presenting was of itself, I suppose, a warning light. I was travelling a lot, and the GP kept telling me I got jet lag because the fatigue was overwhelming. And actually I believed him, because I was, it was stupid, the travelling I was doing, but it never got any better. And then things started to go wrong in terms of my skin and all kinds of other things, and eventually they gave me a fungal treatment which absolutely nearly killed me on its own. So we're now sort of 12 months down the line, I suppose. I kept going back with the same sort of symptoms. Eventually I started to lose my appetite. I could hardly walk into the surgery. And the GP sent me for an ultrasound, which isn't terribly helpful in terms of diagnosing pancreatic cancer, but it did suggest that I might have a problem with the gallbladder. My life-saving symptom was to get jaundice, actually. Because very quickly after, we're now sort of 9-10 months in, I suppose, after the symptoms presented, I turned bright yellow everywhere, and suddenly I went to see my GP again. In fact, I didn't. I saw a newly qualified GP on placement who took one look at me and said, "Can you get to the hospital? Because if not, I'll call an ambulance now, but you're going." And that was critical, actually, because I was admitted that day, spent a fortnight in hospital having all kinds of tests, and it was finally an endoscopy and a series of scans. And a doctor, 2 weeks into my stay, came up to me one day and said, "Well, we're going to let you go home. We're going to refer you. There's some kind of lesion," he said very seriously, not looking me in the eye. And I felt so terrible, so ill, I didn't actually think to ask him what that meant. But of course everybody around me looked very grim, so I suppose I really should have got the message that something was going on. Anyway, I was back in hospital a couple of weeks later for further tests and another endoscopy and a consultation with the surgeon who told me what was wrong. Of course, that's the day when you're diagnosed that you never ever forget. But I have to say that he handled it very well. It was done in private. The NHS do what they do so well, which is they react to. They've now got a diagnosis and they can do things. But what happened is I found myself a few minutes later talking to a surgeon who was going to assist in this surgery that I was now told I was going to have, going through the details of pancreatic Whipple's procedure, and of course I don't remember very much about it really. I couldn't tell you to this day really what was said to me. What would have been helpful would have been perhaps some referral to some support or somebody who could sit me down and talk to me, because I went home and looked it up on the internet and nearly died of fright, because the internet is fantastic, but actually you can learn lots of things that aren't terribly helpful, and it didn't do my morale much good, I can tell you. The surgeon was very good. He was very down to earth, which is what I wanted, a straightforward message. And he also took the trouble to talk to me about my psychological state and what I should prepare myself for. He didn't know me from Adam at that point, although we got to know each other very well over the coming 12 months. And he was fantastic. And he hit the right note with me without really knowing me. He hit the right note in terms of what he could do and how it was going to happen and so on. But as other people have suggested, the NHS is very busy. People work very hard, but you come to dread as a patient. You come to dread the weekends. You come to dread the nights because there's nobody around who can help you. I had surgery. I then had 6 months in hospital. The 12 months prior to diagnosis, bile was leaking into my system and did a whole lot of damage that nobody knew about until they opened me up. But I had sepsis, I had organ failure, my hepatic artery erupted and I nearly drowned in my own blood. And that got worse and worse and worse. I have to say that the quality of care in critical care was utterly fantastic. It just absolutely amazing. And I think the difference, it strikes me, is that actually the hospice movement, and obviously I didn't have to go into one, I'm 3.5 years post-diagnosis, and I'm very lucky. I'm one of 3 people in 100 who get to survive perhaps to 5 years. And also, in East Anglia, my chances of survival were half what they might have been in London. They're 3%. In London, they're 6%. In Northern Ireland, I think it's less than 2%. That can't be right either.
Yeah.
That can't be right. Postcode lottery is I know what it's often referred to, but that doesn't seem to me to be right. So I think communication is key. Look people in the eye and give them proper information, and then communicate with each other. You see, because I think actually what happens, and I think the way that the hospice movement is so different from hospitals, is that the hospice movement is undoubtedly patient-focused. I think what gets in the way in some hospitals sometimes is the professional culture. And who can be in on meetings and who can't be on meetings and who gets to hear certain things. So, reorganisation is one thing, but it's a bit like moving the deck chairs on the Titanic. A change of culture needs to be more than that. Professional culture needs to be more than just moving people about. It does need to look at how people communicate and how the many professions in the medical field interact with one another. And to be focused on us, not on them, as it were. I did have a lot of time with a dietitian. I was very lucky. But the problem was that what the dietitian and I cobbled together as a diet, once I was allowed to start eating food again, was the hospital never delivered it. So my breakfast that was very carefully planned, my fruit allowance would turn up 4 days later than it should have done, and I get a banana with my name on it. I'm not exaggerating. I mean, these are the kinds of idiotic things that happen. And I have to say, if I lived alone, I really don't know what had happened. If my partner had not come in at lunchtime and evening with a meal for me, I don't know how I would have recovered. And that is the luck of the draw. I was very lucky. But that can't be right. And I'm sure it's not just my experience of some hospital catering. It can't be beyond the wit of a system to produce healthy meals on time, or even a banana for breakfast. Those sorts of things are the things that kind of start to get you, I suppose, when you're actually trying to fight for your life. As I say, I think critical care were wonderful. I think the surgeons were fantastic. I don't have any complaints about that. The clinical nurse specialist was also a focal point of my life in hospital, and I think their role is absolutely vital. Someone had a view of the case, because in my case it was so complicated and there were so many medics involved that actually there was one person I could always ask questions of. And critical care had a scheme also where I was in and out of the place so often. They had an overview too and offered me just a space in which to talk about what was happening. If you like, some psychological care, some oversight. And, it was only a pilot scheme, apparently. There wasn't a lot of funding to keep us going, but I certainly benefited from it. So there were some good things in what happened to me, as well as some horrible things. GPs need some help with diagnostics. I know it's difficult. I'm told that most GPs only see one case every 4 years of pancreatic cancer. I don't know if that's true or not. But, like Debbie was saying, actually there were big signals in my presenting the symptoms that might have benefited from some intervention earlier on. And then I might have spent only 3 months in hospital, who knows. The important thing is I survived. And I owe my life to the NHS, so, I want to try and get it into balance.
Yeah. Thanks, Lynn. And you haven't lost your humour either.
Mark. No, that was critical, really.
My name's Mark Horner, and I've come from Northumberland. Here at the invitation of Pancreatic Cancer UK, and I think it's on the basis of a post I made on the website, so I'll just read that, and it gives a background of my experience. So, I'm a 59-year-old GP who was winding down to, at least in my opinion, a well-earned retirement. My wife and I left for a skiing holiday in Canada on the 4th of February, and as far as I was concerned, all was well. Whilst away, I began quickly to have symptoms of mild diarrhoea. Dark urine passed off initially as exercise related, and 8 days into the holiday I began to look yellow and made arrangements to return to the UK. We all tend to think the worst, and painless jaundice has an ominous reputation, and I suspected pancreatic carcinoma from the start, though my surgeon initially thought gallstones more likely. An ultrasound scan was followed by a CT scan which confirmed a pancreatic mass, and then followed an EUS and an ERCP to get a tissue diagnosis and to fit a biliary stent to relieve the jaundice. Both of these needed repeating because of an indeterminate result and sludge blocking the stent. My diagnosis is adenocarcinoma of the pancreas, which is stage 4 and inoperable because of involvement of the superior mesenteric artery and vein. I also have chronic pancreatitis, which I find hard to believe, as I had absolutely no symptoms. I had a central line of Rochon catheter fitted on the 17th of April and started my first cycle of FOLFIRINOX on the 22nd of April, when my liver function was back to normal. My biomarker CA19-9 was 1060. So much for the bare bones. Subjectively, the last 3 months has been a real emotional roller coaster. It's difficult to accept such a serious diagnosis, especially as I felt perfectly well, apart from the itch, which made sleep so difficult. Fortunately, the jaundice is now cleared completely, which is just as well, as it would have prevented chemotherapy. I've developed a pain which is now mostly in the back and tends to wake me in the early morning. This is controllable with paracetamol, which I take 2 or 3 times daily, along with Creon with each meal, and a multivitamin to help with vitamins A, D and K. I'm enjoying my food, have regained the small initial weight loss, I sleep well, and I try and walk for at least an hour a day. I had some qualms about the central line. It does shake your body image when you have a small tube leaving from the centre of your chest, but I barely notice it now. The most noticeable effect from the FOLFIRINOX, the chemotherapy, was some temporary difficulty with speech, dysarthria, and a few hiccups when the bottle was attached. The main danger would be the effect on the blood cells, and I'll find out next Tuesday. This was written on the 2nd of May. I've updated it yesterday and said that the effects on the blood cells were borne out. The treatment needed to be deferred for 6 days because my neutrophils had fallen to 0.5 and the dose was reduced. This meant that the side effects were even less marked than before, and I'm somewhat concerned that the effects on the tumour might be less marked as well. On a more positive note, my pain has virtually disappeared. My biomarker is down to 921, and the recent CT scan found no evidence of metastases. There are reports that FOLFIRINOX, when used in locally advanced but inoperable disease, can in more than 20% of the cases make an operation feasible. This is a long way from cure, but it does give one hope.